Here we are again with the latest news from the website prostatewarriors.com. With the AACR annual meeting 2026 just around the corner, less than a month away, there's a wave of interesting developments coming out of the preclinical space. To keep things manageable, we will mainly highlight the studies that are about to move into phase 1 clinical trials.
Right, which is always the exciting part.
Yeah, absolutely. So imagine you are trying to put out a fire in your kitchen. For decades, the standard approach in oncology has essentially been to, flood your entire house just to extinguish those localized flames.
And, I mean, it works, but the water damage to everything else is just catastrophic.
Exactly. So today we are taking you to the absolute bleeding edge of medical science to see how that paradigm is shattering. Welcome to our latest deep dive. Our mission today is to really bridge that massive gap between the incredible biology happening in the labs right now and the tangible therapies that are about to hit the clinic for you or your loved ones.
And, to really understand what is at stake here, we have to look at the adversary. The current standard of care for prostate cancer is undeniably excellent. We have some really powerful tools.
We do.
But prostate cancer is not a static target. It's a master of evolutionary adaptation. You hit it with a drug and it actively rewires its own biology to survive.
It's so stubborn.
It really is. So the theme of today's deep dive is how we outsmart an outsmarting disease.
I love that. Let's ground this first by looking at what is actively happening in clinical trials and real-world data right now, before we start zooming too far over the horizon.
Good idea.
There's this fascinating development regarding an investigational anti-androgen implant called Enolen. This is currently in an early phase 1 study. We were talking about men with localized prostate cancer who are scheduled to have a prostatectomy.
Right, so early stage.
Exactly. But instead of giving them a systemic pill, surgeons are placing up to 16 microscopic implants directly inside the localized tumors. These tiny devices continuously release the drug enzalutamide right into the tissue. In just about 5 weeks, they're seeing an 84% reduction in tumor volume.
Wow. And, the clinical significance of that localized delivery just cannot be overstated. Enzalutamide is a very potent, systemically approved anti-androgen.
But the side effects can be brutal, right?
Exactly. When a patient takes it orally, that drug circulates through the entire bloodstream. It bathes the brain, the muscles, the bones, and that leads to the profound hormonal toxicities that patients find so difficult to tolerate.
Right.
But by utilizing the Enolen implant, researchers are finding massive concentrations of the active drug actively suffocating the tumor inside the prostate, while the systemic drug levels floating around the rest of the patient's body remain, well, barely detectable.
So it's basically a smart bomb versus carpet bombing.
That's a perfect way to put it.
You are delivering the payload right to the prostate without putting the whole body through chemical hormone deprivation, meaning, no severe testosterone suppression, and you're sparing the patient from sexual dysfunction and fatigue.
Right, and it represents a fundamental shift in neoadjuvant strategy. Shrinking a tumor significantly before a surgeon ever makes an incision dramatically reduces the risk of positive surgical margins.
Meaning less chance of cancer cells being left behind.
Exactly. And doing that without subjecting the patient to long-term hormonal consequences is just a massive win.
And speaking of long-term consequences, we're also seeing fascinating shifts in how existing oral drugs are performing in real-world data. There's this massive retrospective study called DEAR-EXT.
Ah, yeah, the DEAR-EXT study.
Yeah, it looked at over 1,300 men with non-metastatic castration-resistant prostate cancer, or nmCRPC. And it showed darolutamide had a 25% or greater reduction in the chance of a patient having to stop treatment compared to enzalutamide and apalutamide.
And the primary driver forcing patients off those other therapies is usually the accumulation of adverse events, with crushing fatigue being the most prominent.
Right. Fatigue is huge.
It is. But darolutamide was specifically engineered to be highly polar, meaning it struggles to cross the blood-brain barrier. So less of the drug gets into the central nervous system, meaning significantly less fatigue.
Oh, that makes so much sense. And it also showed a lower risk of progression to metastatic disease and deep PSA responses, like PSA 90. Though, we should note, it is a retrospective observational study.
Which always carries limitations compared to a strictly controlled phase 3 trial, yeah.
Wait, let me push back on this for a second, though.
Sure.
If real-world data shows drugs like darolutamide are keeping men metastasis-free longer, and we have these implants shrinking tumors early, why do we need this massive wave of new phase 1 drugs? Aren't we already winning?
I get why you'd ask that. But if we connect this to the bigger picture, the cancer eventually mutates. It changes its locks.
Okay, what do you mean by changing its locks?
Think of the androgen receptor, the AR, like a physical lock on a door. Hormones like testosterone are the keys. When the key turns the lock, it opens the door for the cancer cell to grow.
Got it.
Our current best therapies work by either hiding the body's keys or physically jamming that lock. Over time, though, the cancer responds by literally changing the shape of its locks. It mutates the receptor, so our clinical drugs just physically bounce off.
Wow, okay. And one of the ways it does that is by creating shortened variants, right? Like AR-V7.
Exactly. The tumor cuts off the entire keyhole entirely. Because AR-V7 is missing that keyhole, it doesn't even need a hormone to grow. It just stays permanently turned on.
Which brings us perfectly to how the new drugs entering phase 1 combat this. Since the cancer adapts by mutating the AR or creating AR-V7, how do we bypass that resistance?
Well, we're seeing experimental molecules that don't just block the receptor, they obliterate it. There's a drug heading for a phase 1 trial called FX11.
Whoa, the Prostate Degrader.
Yeah. Yes, a selective PROTAC degrader. It's basically a molecular hitman. But what makes FX11 so special is that it specifically targets the active hormone-bound AR, what researchers call AR-ON.
Wait, if FX11 works regardless of hormone levels and specifically degrades it even if the tumor is flooded with androgens, could this mean men might one day skip traditional ADT, like chemical castration, entirely?
Yes. I love your enthusiasm there because that is exactly why FX111 is such a paradigm shift. It challenges the foundational rule of androgen deprivation.
That is just incredible.
It really is. It perfectly suppresses AR-dependent transcription without off-target effects. But we still have to deal with the AR-V7 variant that doesn't use hormones at all.
Right, the lock with no keyhole.
Exactly. And that's where another small molecule, JMKX007129, comes in. It's moving to phase 1, and instead of trying to bind to the standard keyhole, the ligand binding domain, it targets the N-terminal domain, or NTD.
The upstream tail part.
Right. It's 20-fold more active in AR-positive cells, and because both full-length AR and AR-V7 share that same tail, it binds to both.
And then there's the team that screened 170,000 different molecules to find a dual AR-V7 and AR molecular glue.
Oh, the molecular glue, yeah. That's fascinating.
It acts as a glue that sends both the full-length AR and AR-V7 to the cell's garbage disposal.
Yeah.
The ubiquitin proteasome system.
And the data there is incredible. In mice, it showed a 10-fold potency advantage over an earlier drug, AR-V10, and it did it without causing weight loss.
But wait, what if we don't use the proteasome? We just talked about trashing the machinery, but what if we use the cell's other disposal system?
Right, the autophagy lysosomal machinery.
Exactly. There's a new class called AUTOTACs, ATB 238 and 239. They force the cancer to use that lysosomal machinery to basically eat the AR and AR-V7.
And that approach has been highly effective in bone metastasis models. Bone is the most common site for it to spread. Plus, it synergizes perfectly with the chemotherapy docetaxel.
Okay, but what if we don't destroy the AR at all? What if we just confuse That brings us to Daltax, specifically JZY3032.
Yes, domain-alteration chimeras, a totally new class.
Instead of destroying the AR, JZY3032 targets the ARP300 complex. It links them together in a jammed topology so they can't communicate or turn on cancer genes, leaving the proteins completely intact but useless.
What's fascinating here is that this topology-only intervention spares normal tissue.
Oh, because the proteins are still there.
Exactly. Normal cells might rely on the natural presence of those proteins, so by just jamming the interaction, you aren't wiping them out globally.
So instead of blowing up the enemy's radio, you're just rewiring it so it only broadcasts static.
Yeah.
The radio's there, but the signal is dead.
That's a great analogy, yeah.
Okay, so blocking the AR is great, but eventually we need to bring in the heavy artillery, the immune system. But prostate cancer is notorious for being an immune desert. It's a cold tumor. How do we heat it up?
You have to force an engagement, and that's where HLX3902 comes in. It's an IND for Q1 2036. It's a trispecific T-cell engager.
Trispecific, not bispecific.
Right. Traditional bispecifics only give T-cells signal 1, which just leads to exhaustion. HLX3902 grabs STEAP1 on the tumor, but gives the T-cell both signal 1 through CD3 and signal 2 through CD28.
Oh, so it gives it the ignition and the gas pedal.
Exactly. It creates these memory-like CD8 T cells that just don't burn out.
That's amazing. But how do we get these large new drugs like PROTACs inside the cells to begin with? There are two delivery innovations that just sound like sci-fi to me. First, Ferroptosis-Nanoparticles.
Oh, these are brilliant. They're tiny particles carrying docetaxel and a light-activated dye called AR-808.
And because tumors have high hydrogen peroxide, that triggers the drug release, right?
Yes. Then they use near-infrared light to heat it up to 60 degrees Celsius in just 5 minutes.
Which is wild.
It is. This triple threat causes ferroptosis, meaning the cell membrane literally bursts. That completely wakes up the immune system, turning a cold tumor hot, and shows massive synergy with anti-PD-1 therapies.
And the other one is SonoPIN. They use microbuttles and focused ultrasound to create temporary pores in cancer cells, allowing massive PROTACs to slip inside. They achieved a 70% reduction in target proteins.
And it killed half the cancer cells while sparing 99% of healthy cells.
Okay, SonoPIN sounds like pure sci-fi. Blasting cells with ultrasound to open tiny doors. How on earth do we ensure that doesn't just shred the surrounding healthy tissue?
It's all about precision. The microbubbles are coated with synthetic nucleic acid homing strands.
Homing strands.
Yeah, they only stick to tumor cells. So when the acoustic shock wave hits, it only affects the targeted cancer cells and ignores the healthy one.
Wow, okay. But what happens when the cancer pulls its final trick? When it stops looking like prostate cancer altogether?
You're talking about treatment-emergent neuroendocrine prostate cancer, or TNEPC.
Right. It loses AR dependence entirely. It's like the cancer puts on a fake mustache and slips out the back door to avoid AR drugs.
That is exactly what it does.
And TBI-001 is the security guard that recognizes the disguise.
Right, because TBI-001 targets TRIB2, which drives that neuroendocrine state. It degrades TRIB2, dropping aggressive markers like CD5-6 and DLL3.
Ripping off the disguise. And how do we find better targets to blast with radiation when it hides in the bones?
We're moving to next-generation alpha radioligands like 225 ACRAX104. Moving to phase 1, it uses actinium-225.
And it has a 22-fold higher affinity for PSMA than Pluvicto's ligand, right?
Yes, because it dissociates slower. It delivers massive radiation locally with far fewer side effects. And speaking of bone metastases, there's an OSMR-CRRT therapy originally for osteosarcoma, a bone cancer.
Oh, right. And because the OSMR receptor drives metastasis in prostate cancer, this opens a conceptual door for targeting prostate bone mets.
Exactly. We can port that therapy over.
Which is just incredible. But with all these hidden targets, how do we find them?
AI specifically, AI tools like CellVoyager.
Which acts like a computational biology postdoc. It reads past research and single-cell RNA-seq data and then actually proposes and runs new biological hypotheses automatically.
Right. It synthesizes massive amounts of data to find hidden signals in old data, uncovering targets like OSMR or TRIB much faster.
So, bringing this all home, we've covered a lot. From the localized precision of the Enolen implant to the sci-fi reality of ultrasound microbubbles and PROTACs, right up to AI-driven target discovery. The preclinical pipeline is just exploding with innovation.
It really is. I want to leave you with one final thought to mull over. If AI can act as a junior postdoc, continually remining old data while you sleep, how many cures for cancer are currently sitting undiscovered on a hard drive from 5 years ago, just waiting for an algorithm to connect the dots?
Wow. That is a truly profound thought to end on. Thank you so much for joining us on this journey today. Stay strong and fight on.